Firstly, thank you very much for having me. It's a real pleasure to be here and to be amongst like-minded people who are trying so hard to try and progress the work and what we do with patients who have had organ transplants. So just a little bit about my background. So I'm a physiotherapist by background. I started off my career specialising in musculoskeletal therapy, and at a very, very young age, I decided I wanted to be a cricket physio. However, that quite quickly changed once I started working in the health service. It was while I was specialising, I specialised as a senior physio in musculoskeletal, that I saw a little bit about what was happening in the renal unit, and they were trialling some of the old-fashioned types of dialysis bikes. So I went along and spoke to some of the nephrologists about what was happening, and we got a little bit of time to try and help with the programme. And that's where my time in renal started. We then sort of progressed on with the renal weight management programme, which Ellen spoke to you about. And quite quickly, being part of a very like-minded, research-orientated clinical service, my interest was really piqued in terms of what we could do for these patients. I think also, having worked as a junior physio around all the areas and seeing what was offered for cardiac patients, what was offered for patients with pulmonary problems, I was really surprised to find very little being offered for patients with CKD across the trajectory. So that's where my sort of interest in research started. So I completed my PhD a couple of years ago, and I chair the UK Kidney Research Consortium Exercise Study Group, which is a consortium of experts from around the country, and I'm quite proud I'm the only non-medic lead of one of those groups in the consortium. The other job I have is I chair the British Renal Society Rehabilitation Network, and I work in that area in terms of trying to improve implementation, but also linking implementation with research. So that's a little bit of the background. So today I'm just really going to talk a little bit about the actual kidney transplant part of the service that we run. I'm not going to talk about the EXERT study, because that's what I'm going to talk about on Friday, and I'm going to bore you all to death if I talk about it today and on Friday. So firstly, just a little bit about the problem. So the problem we have, and I know Roberta touched on some of these problems this morning when he was talking. So we know that 4% of the NHS budget is spent on kidney failure services, and the cost of maintaining a patient on hospital haemodialysis averages at £35,000 a year. Kidney transplantation costing an average of £17,000 a year, and then a subsequent £5,000 for every year that we can keep the patient with a functioning graft, is highly cost effective, and it's the treatment of choice for most patients with end-stage kidney disease. I think this is falling off, is that it? Okay. So as well as problems with long-term graft survival, kidney transplant patients have a 50-fold higher annual risk of fatal and non-fatal cardiovascular disease events when compared to the general population. It's estimated that 2/3 of the kidney transplant population is overweight or obese, and exercise capacity is 30% lower than that of the general population. Due to a national shortage of kidney donors, it's imperative that we maintain the health of each kidney transplant patient, because we need to make best use of the kidney, but also best quality of life for the patient. Weight gain, especially in that first year of kidney transplantation, is a significant problem. And despite that, routine physical activity and weight management interventions aren't offered to kidney transplant patients in the NHS, and we think that this is a problem that needs to be urgently addressed. So my brief really was to talk about the different types of guidelines that we have. And in the UK, in terms of physical activity guidelines, we have the Start Active, Stay Active guide, and this has been produced by the 4 home counties, so Ireland, Wales, Scotland and England. It's the chief medical officers. And this will look quite familiar because we were just talking about this. So I haven't concentrated on children. I've just gone with adults. I don't really specialise in children. So adults should be active daily. So over a week, activity should add up to at least 150 minutes of moderate intensity activity in bouts of 10 minutes, or alternatively 75 minutes of vigorous intensity activity, or a combination of moderate and vigorous intensity activity. So like was just mentioned in the previous presentation, those are quite obviously exercise guidelines rather than physical activity guidelines. However, what I will say is that I think it's important, however patients can manage this, that if this is what we have, this is what we need to work with. So although it is important to be active over the whole 24-hour period, if we've got something like this, at least we've got a starting point of telling our patients some useful advice of what to do. Included in that for adults 19 to 64 is muscle strength activity on at least 2 days of a week, and to minimise the amount of time being sedentary or sitting for extended periods. It's the same guideline for older adults, so 65 years plus. They recommend the same amounts of activity. However, they also add in that older adults who are at an increased risk of falls should incorporate physical activity to improve balance and coordination on at least 2 days of the week. So we have a few different guidelines which are renal specific in the UK. So the Renal Association is one of our big societies. We have the Renal Association, we have the British Renal Society, and their guideline, which is guideline 1.4, it's in cardiovascular disease risk. And they suggest that exercise should be encouraged, and patients, including dialysis patients, should be enrolled on regular exercise programs, exercising 3 to 5 times a week, either during dialysis or between dialysis sessions. So that is the only guideline that the Renal Association has in relation to physical activity and exercise. Some of you might have seen this. This is the British Association of Sport and Exercise Science. This is the expert statement, which was produced by Dr. Kafaki, myself, Patricia Painter from America, and also Professor Tom Mercer from up in Edinburgh. And these were some of the bullet points, so the highlights, if you like, from the statement. Again, this is based on the limited amount of evidence that we have. So most of the studies which have been done in this area, and I think this was also mentioned before, they're small, they're of short duration, and because they're of short duration, none of them have been long enough to really look at the effects in terms of morbidity and mortality. But the bullet points were to enhance confidence and self-efficacy in performing physical activities, to attenuate deterioration of physical functioning and associated limitations in activities of daily living, to increase physiological reserve, to reduce comorbid events, and to enhance quality of life. The KDIGO recommendations, which was again in the previous presentation, say that patients with CKD should exercise regularly, aiming for 30 minutes 5 times a week. So I think you can see there's a general theme here. We actually don't have anything particularly different for renal patients than what's actually prescribed in terms of physical activity for the general population. So why aren't all our renal patients exercising? That's the interesting point. So that brings me on to what we do. So this is what we do in our kidney transplant clinic. So what I will say is this is not something which happens all the way across the UK. I think we're one of a few centres which offers a kidney transplant clinic advice service. And what we base this on is individualised and individually tailored physical activity advice. So we look at patients' baseline levels of fitness, and we tailor the activity to suit them and base it also on their patient preference. CBT therapy, so like Ellen said, she gave a lovely summary of all the reasons why we use motivational interviewing, and we use the patient preference, we use the patient-centered goals. We get the patients to come up with what it is that they would like to change. There's no use whatsoever, and I like Ellen, for years told my patients what to do, and they'd come back and I'd be like, why haven't they done it? You know, I've told them that it's good for them. I've told them what to do, and they come back and why haven't they done it? So actually learning about motivational interviewing completely changed my practice, and it really is the cornerstone of what we use now. We have a big focus on weight management. So I do a bit of this from the clinic. We don't actually have a dietitian assigned to the renal transplant clinic, but we can refer the patients into our renal weight management programme. The problem we have with that is only offered on one afternoon of the week, and these transplant patients already come in for 3 appointments. So they have a high patient appointment burden, and sometimes that coming in for the extra appointment is that step too far. So we do try and do what we can from clinic with the patients. We do use some measures, and I'm actually going to just go forwards and then I'll come back. So one of the measures we use, which is just very easy, this goes out with our annual review for our patients, and we use it also just generally in clinic. This is the Duke's Activity Status Index. Have people come across this before? Anyone come across this? No? So this is validated for use in patients with CKD, and it's a really nice measure because patients can score this. They don't see, this is just so you can see the scoring, they don't see the weighting, they just see the yes and no to the questions, but they're individually weighted according to the difficulty of the activity that they do, and there is a calculation at the end if you want to work out the METs from that. But what we use it for is to see what the patient's score is and actually to see the changes in the scores from the physical activity type intervention that we introduce. So we monitor this in every patient during annual review, and then we can see from that if they're actually improving or they're getting worse, and we can change our measures accordingly with that. I'll skip back. So Ellen talked a little bit already about our annual review, so it's a little bit like a car MOT. They address everything from skin, teeth, nails, all the way down to physical activity. And this is where we play a key role. And I think what happens quite often is with kidney transplant patients is as soon as they're up and moving around, people see that as being okay, and the patient comes in and they say, oh, are you doing activity? And they say, oh, yes, I'm doing activity, and they get a tick in the box, and that's that. Whereas if they come and see us, we delve into it a little bit more. So we say, well, what is it that you're doing? You know, does that activity make you breathless? Do you think you could do more? And it's really about trying to progress every patient. And we know that our bodies are incredibly clever, and whatever activity it is that we're doing, we accommodate to. So we always need to be pushing those boundaries. So all these patients need to progress and be motivated to progress and to keep going. Otherwise, like David was saying, you finish your exercise program and then you get this deterioration off. So what we're looking at here in our clinics is we're looking at maintaining our relationship with these patients and maintaining a lifestyle change as opposed to doing a single intervention. With our new kidney transplant patients, this is an area I'm very keen on. So, like I said, it's the first year of kidney transplantation that these patients have a significant weight gain, and we know it's a very, very big problem. So I think if we get these patients early and we can intervene and be a part of the team, and they see this as being a big, important part of it, that we can actually try and help to stop this decline happening from when the transplant happens. In terms of the obesity side of things, or the increase in weight gain, these patients are on prednisolone, and a lot of patients will come in and say, it's the steroids. It's not me, it's the steroids. And sometimes just some careful explanation that it's actually the steroids don't have the capability to make you increase weight. What they do is make you more hungry and make you want to eat more. And sometimes having the resources to help with those unhelpful behaviours, so to help with, say, the cravings, can be the difference between a patient understanding the need to monitor what it is that they're eating. The other problem that they have is that a lot of them who've been on dialysis have been on very restricted diets. So they're restricted because of their potassium, because of their phosphate, and all of a sudden, after having a kidney transplant, they've got a whole array of foods which become open to them. We came across one person who loved bananas so much and they'd been cut out of their diet because of the potassium while they were on dialysis, and they started to eat between 15 and 20 bananas. So, this is where we get a bit of a problem. So sometimes just having that healthy eating advice and the resources to help combat some of those behaviours can be very, very useful. So we see them straight away as they come to clinic. So like within the first week when they come along, and we tell them it's okay, it's fine, get walking. There's no reason to sit around. We don't want you doing too much, but you can walk, you can start going up the stairs, and start even working into a bit of breathlessness. When they hit 6 weeks, we want them to really get going. And this is the point where I think people are still sitting and still worried about what they're going to do to their kidney. So this is the point where I think we have a big role to play in combating those fears around exercise and the transplant. And some of those are cultural. Some of these patients see themselves as being sick. They've had a transplant and they don't see themselves as having a new lease of life. They see themselves as a transplant patient. But also just some patients, they feel, I mean, they're so protective. It is their new lease of life and they don't want to do anything to damage it. So sometimes just talking through exactly what it is that's happening when you're exercising means the difference between these people actually pushing into that breathlessness and getting some of those benefits. We offer renal rehab at this point for patients that can reach us geographically. It is one of the problems we have. Patients come from far and wide, and renal rehab is offered near our hospital. It's been replicated at Guy's Hospital and also in York, but that's about it. So it's not actually offered in anywhere else in the UK. They do some, so I know David's from Loughborough and at Leicester, they do some research work as well with these patients. But in terms of clinically commissioned services, we're still a long way from actually getting this commissioned across the UK. One of our things that we say is to avoid full contact sports, so such as karate or rugby, and initially we avoid strenuous abdominal exercises, so that's for the first 6 months. And our surgeons and our nephrologists are very keen on public swimming jacuzzis and saunas in terms of the infection risk. So certainly for the first 6 months, they are quite keen that they aren't involved in those sorts of activities. So having said a little bit about what we do in the UK and some of our guidelines, one of the things that I was asked to do was to have a look at the physical activity guide. And I'm not going to stand here and tell you all the things that I think are good or bad about it, but I think it's nice to have a discussion about some of the things which are in this diary and some of the things that we maybe tell our patients to do and see what we think are the good things that we can take from this guide and our guide and possibly start working towards maybe doing more common guidelines, more European guidelines. So this is our exercise diary. So I'm going to tell you a little bit about what we give for patients. And I think what was quite interesting was you were mentioning about the guide being quite sport, being designed for quite sort of sporting activity rather than new patients. And quite possibly our guide is maybe tailored more to the newer patients. And possibly that's where a nice point between the two might come into play. So in our diary, we talk a little bit about why inactivity makes you worse. So we talk about this cycle, about doing less activity, muscles weakening, you becoming more breathless and unfit, and then how you break the cycle. So we find that this is actually very interesting for patients. Patients don't always understand what breathlessness is, and they see breathlessness as being something which is symptomatic of something wrong happening or them pushing themselves too much. So understanding this can be quite helpful. We talk about the benefits of exercise, so very similar to the guide that has been produced for Finland. How to exercise safely, so things like warming up, cooling down, wearing the appropriate types of clothing, making sure that you stay well hydrated. When to stop, so this has been quite helpful. Patients like to know how far they can go and points where something maybe is going wrong and when to stop. So we give them some ideas with that. There's then different ways to exercise. So about being able to exercise anywhere. So people like to do different things. Some people like working in groups. Some people like going out. I think you were mentioning, Liz, going out on your bike on your own. So, exercise ticks different people's boxes. So it's about finding different things that different people enjoy. How often should I exercise? So we have where we say 3 to 4 times a week, starting 20 minutes, progressing up to 30 minutes, and how it should feel. One of the most useful things that we use is about saying a sentence. So we say to a patient, we usually choose something the patient has said. So the patient might say, I want to do some exercise because I want to lose weight. So it's quite helpful we repeat back to the patient. If you were to say that sentence, so I want to do exercise because I want to lose weight, you want to be exercising at a point where you go, I want to do exercise so I can lose weight. And we say that that's at about your 13 to 15 RPE scale. And we find that that's just the most useful way for patients to be able to gauge that. So we say if you're breathless and you're having to take those breaths, that equals the benefits. And quite simply presented, that seems to be quite useful. So this is our exercises that the patients can do. So there's a combination of warm-up and then the exercises. We say to patients they can use cans of baked beans or bottles of water, or pick up some cheap exercise weights to use. You can see there's quite a lot of different exercises there for them to follow. And then there's, very importantly, a cool down and some of the stretches that we get patients to do. We do get patients that suffer from cramps and pain from not stretching properly, and that's something that we have a very big role with in helping. And that's just the exercise diary. So we have about 10-15 pages of this in the back. Patients record what it is, how many they do, and what we do is we give them an RPE scale and we explain about that breathlessness. And once they start to not be breathless in whatever exercise it is that they're doing, that's the point where they start adding on another 2 or 3 of whatever it is that they're doing in terms of the exercise. So what I thought would be quite useful now would be for us just to have a bit of a discussion about what are the useful bits of the 2 different types of guides. So the Finnish guide brings together all of the organ transplants in the guide. And I'm not saying this is the right or the wrong thing. Is that useful? Is that the way that everybody thinks is the way to go, or is it more useful to have disease-specific guides where you bring into play all of the different problems which patients might consider in terms of their specific type of transplant? One of the things I found interesting, and again it's not a right or wrong, but is including the dialysis and the peritoneal dialysis, so the hemodialysis and peritoneal dialysis in a transplant activity guide. And is this the right place for it, or are we aiming at the same group of patients, if you like, or are they different, and do they have different needs? I think they do, and I think I'm going to be a bit challenging here. I think we should have hemodialysis or pre-dialysis hemodialysis booklets, and I think we should have transplant booklets. But again, that's not a right or wrong. That's just a personal opinion. What I will say is in terms of evidence-based recommendations, there is a lack of conclusive evidence. So until some of these bigger studies are done, we don't have conclusive evidence to say exactly which types of guidelines we should be doing, but we can give recommendations and we can say what we recommend patients should be doing. And I think it would be really nice to be working towards more common guidelines, and certainly more common European guidelines for this. And Liz mentioned, and it was the first I'd heard of it, was the Fit for Life in terms of the transplant guidelines, which she is doing this year in Hong Kong. It's a baby in progress. A baby in progress, yeah. And again, when looking at recommendations, you'd be thinking about modality. So again, what stage of CKD, or what, I'll always talk from a CKD background because that's my speciality, but again, in any type of transplantation, different types of exercise prescription, and then the intensity and the training duration. Or is that a step too far without the actual evidence? Can we give recommendations on that, or should we be sticking to the more broad guidelines and working harder in terms of trying to get patients just to initiate exercise? So what I'm going to suggest is just on your individual tables, I'm going to leave those questions out, maybe have a think about those, and then we'll come back together and talk about it. Should we do the talk first?
Maybe.
Yeah? Okay, we'll put these up again. we'll just swap over. There's one more presentation to give, and then maybe we'll just spend a few minutes talking through some of these ideas. Thank you.